Welcome, everyone. Thank you for joining us today. My colleagues and I are part of the colorectal disease management team here at Stony Brook University Hospital. And this is the Colorectal Awareness Month. And so today we're going to be discussing best treatment options for colorectal cancers. My name is Alex Stessin. I'm one of the radiation oncologists here at Stony Brook, and I'm joined by my colleagues, Dr. Deborah Nagle, who is a chief of colorectal surgery, and Dr. Julie Gemmill, who is a medical oncologist. So I'll give you guys a chance to briefly introduce yourselves. Dr. Nagle.
Hi, I'm Deborah Nagle. Thanks for joining us today, and we look forward to our discussion on management of colorectal cancer.
Okay, Dr. Gemmill.
Hi, everybody. My name is Julie Gemmill. I'm a medical oncologist and hematologist here at Stony Brook. I care for patients with all types of GI cancers, as well as patients with benign or non-cancerous blood disorders.
Great, thank you. So just to tell you a couple things about the format, this is meant to be interactive. There's a chat function on the side of the screen, so please feel free to ask questions during this hour, and we'll see them and ask them to the presenters. So as I mentioned, we're all part of the colorectal disease management team, and the way that cancer treatments work at Stony Brook University Hospital is that each cancer site has a multidisciplinary disease team that works together that includes the surgeon, the medical oncologist, radiation oncologist, as well as pathologist, radiologist, and all the ancillary staff. And we work together to provide the best cutting edge and personalized care to our patients. And of course, the care starts with screening. And in colorectal cancer, we're lucky because it's one of the cancers that can be screened for and should be screened for. And the recommendations currently are to schedule your first screening colonoscopy at age 45. This is based on national trends that show a decline in colorectal cases and deaths in older individuals, older than 65, but actually an increase in patients who are younger than 55. And so previously the recommendation was to start screening at 50. Over the past several years, it's changed and it's now at 45. It's really an opportunity to detect early, increase survival, increase cure rates. And with that said, there have been some barriers to screening. Some patients are apprehensive about the procedure. It's considered to be invasive. There is prep involved. And so we're going to spend a few minutes discussing the different screening modalities and what it involves, and hopefully assuage some of those fears and convince you that screening is necessary and important. So Dr. Nagle, could you tell us, is colonoscopy the best screening methods? Are there other things out there? What do the patients expect?
So we do believe that colonoscopy is the best screening method, and that reason is because we can both find and remove polyps, which are precancerous growths, at the same time. So it's the only screening modality that we have that also treats the precancerous lesions. That said, a lot of people do have fear or discomfort around the idea of colonoscopy. And so the best screening test is the one that you do. It's the one that you will actually undertake and follow through with. And so knowing that, there are other options. There's a stool-based test that looks for cells from growing lesions, either polyps or cancer, in your stool. And that is an easy at-home test that a lot of patients find really comfortable. And we also say that there's stool test for blood, which can be helpful for some patients because it's easy to do. Not as good a test, but again, better than no test. So we currently recommend either the stool-based test or colonoscopy. If the stool-based test comes up positive, it doesn't mean you necessarily have cancer. It could mean there's a polyp in there. And so if the test comes back positive in any way, we always recommend that you move forward with colonoscopy. But for a good number of patients, it could be that you have the stool-based test and then a colonoscopy can be forestalled for some time.
Okay. Great. And of course, one of the things to consider is family history, which is not to say that if there is no family history, you don't need testing, but certainly anybody with family history should be particularly attentive to getting their testing done on time. And also may want to think about, well, everybody may want to think about ways to reduce the risk of developing colorectal cancer. Dr. Gemmill, could you tell us a little bit about that?
Sure. So when I think about risk factors for colorectal cancer, I basically think about them in terms of modifiable risks and non-modifiable risks, meaning what can I change and what can I change, okay? So things that can't be changed, of course, are genetics. We know that colon cancer tends to run in families, and having one or more first-degree relatives with colorectal cancer increases our risk. So first-degree relative meaning a parent, a sibling, or a child. Okay. People with a history of inflammatory bowel disease also have an increased risk for colon cancer, especially ulcerative colitis, and may require earlier screening, earlier than the recommended 45 years. Diabetes increases our risk, and ethnicity. So we know that African Americans have the highest colorectal cancer rates of all ethnic groups in the United States, and these cancers tend to occur earlier. Now, things that we can change with simple lifestyle modifications and interventions, obesity, smoking, alcohol use, Western-style diet. When I'm counseling my patients, I really encourage them to adhere to a healthy diet that's high in fruits and vegetables, high in fiber, limiting their amount of the red meat that they intake and processed meats. I encourage them to achieve and maintain a healthy diet, to quit smoking, to reduce alcohol consumption, and to increase their physical activity.
Okay, that's great. Yeah. So let's talk about what happens, if somebody has been screened and found to have a colorectal polyp or, something that looks very suspicious for being cancerous, right? So what are the next steps in the workup, right? Well, the patient will probably have some labs, some blood work done, right? And also some imaging with CAT scans or MRI, probably both, sometimes PET scan to see, first of all, the extent of the disease locally, and also the systemic spread, if this is a cancer that is spread anywhere else other than where it started, right? At some point, you'll absolutely need a biopsy, right? And the biopsy is what either confirms that this is a cancer or rules out cancerous growth. And then, of course, genetic testing, right? So genetic testing, when people think of genetic testing, they think of it in terms of risk and risk for family and so forth, but there's also genetic testing to be done, of course, on the tumor specimen itself to better characterize it and, what its behavior is expected to be and what are the best strategies for treatment. And so this kind of brings us to treatment, and the mainstay treatment for colorectal cancer, even though obviously all three of our modalities play a role: radiation, chemotherapy, and surgery. But let's start with surgery, because that's really the first and mainstay treatment for colon and rectal cancers. So Dr. Nagle, what are the surgical options, and what do you advise patients?
So Alex, the surgical options depend on where the cancer is and how far along we think it is. In some patients who have screening, we find the lesion so early that it can, in some cases, be removed just with a scope procedure. It's not a routine colonoscopy. It would be more of an advanced colonoscopy where the layers of the bowel wall are separated to free that tumor and pop it out. So that's an option for some people that has been developed in the last 10 to 15 years. The mainstay of surgical treatment for many years has been traditional open surgery, where you think of having a cut up and down the middle of your belly, and we go in, we find the tumor, and we take out the tumor with its blood supply and its lymph nodes. So that's our surgical goal, to remove it completely and cure the cancer. In recent years, minimally invasive techniques have been used, and that means laparoscopic surgery. I think most people are familiar with laparoscopic surgery, but small cuts, like my fingernail, are made in several different spots in the abdomen, that allow for access to the area of the bowel that has the tumor, and the same surgical goals are performed of removing the tumor and the blood supply and the lymph nodes all in one piece. So that has advantages for patients in terms of return to normal activity, decreased pain, better cosmesis for some patients, and quicker ability to move forward with additional treatments such as chemotherapy if they're needed. In the even more recent past, so in the last decade, I would say, robotic surgery has also come forward for minimally invasive technique. Again, small cuts in the abdominal wall, small incision to take out the specimen or the tumor, but it actually has some additional benefits in terms of reach and access and ability to reconnect the bowel on the inside rather than making a slightly bigger incision to take it out. So that's where we are now. We have a good array of options for patients, and your surgeon will customize the plan based on your personal history, whether you've had surgery before and where your tumor is.
Okay, great. So I told you this would be interactive and we'll take questions throughout this talk. So before we move on to the systemic therapy options and have Dr. Gemmill tell us a little bit about that, we have a couple of questions and comments from the audience. So we have Jessica, who says that she is 45 and diagnosed at 40. The question is, there's also a comment and question from Robin, it's about having colonoscopies from an earlier age, which certainly is indicated when appropriate. And so the question there is, should someone with a family history and no polyps get genetic screening? All right. Let's see. Who's going to take this question? I think the short answer is yes. That family history is an indication for genetic screening, should be done, and is usually ordered by the patient's primary doctor. Do you guys have any comments about that, Dr. Nagle, Dr. Gemmill?
Yeah, I can chime in here. So usually we recommend screening colonoscopy 10 years before your first degree relative is diagnosed with their cancer. And in terms of genetic screening, you should of course have, you should be tested, and your children should be tested for any genetic conditions that might run in your family.
Okay. All right. So Dr. Gemmill, do you want to continue and tell us a little bit about the systemic therapy options for colorectal cancers?
Yes, sure. So I'm a medical oncologist, and so I specialize in the use of systemic medical therapies that target and destroy cancer cells throughout the body. And my therapy options include standard chemotherapy, newer immunotherapies, biologics such as monoclonal antibodies, and other targeted agents that inhibit cell signaling pathways to prevent tumor growth or cancer growth. And when I'm deciding upon a systemic medical therapy regimen, I like to think of patients as having either early stage colorectal cancer or advanced stage or even metastatic colorectal cancer. So for early stage colorectal cancer, we know that some patients can be treated and even cured with surgery alone, but others may require additional surgery, additional chemotherapy, additional treatment. And we call this adjuvant chemotherapy when treatment is given after surgery. So in deciding when to give adjuvant chemotherapy, I risk stratify patients, and I look at their cancer's clinical characteristics, its pathology, and molecular features. Now, in patients with advanced cancer, metastatic cancer where the cancer has spread beyond the colon, in addition to using standard chemotherapy, I can also evaluate the tumor's molecular and genetic profile. And I do this in order to identify mutations that can be targeted with therapy, such as immunotherapy, biologics, and those targeted agents that I spoke about. And overall, my goal is to create a treatment regimen based on my patient's individual cancer biology, that prevents the cancer from growing and progressing, and that minimizes side effects.
Very good. Tell us a little bit more about immunotherapy, what it is and what its role is.
Sure. A lot of my patients ask me about immunotherapy, and it's because immunotherapy has really revolutionized the way we treat cancer. It's now become standard of care as first-line therapy for various cancers, and including select patients with colorectal cancer. Immunotherapy works by essentially harnessing the immune system to fight cancer. And it does this by preventing the cancer from being able to evade the immune system. And it also enhances T-cell mediated cell destruction, so cancer destruction. Because immunotherapy has a unique side effect profile and it really enhances the immune response, it's not recommended for patients with pre-existing autoimmune or inflammatory bowel disease. And you should tell your doctor if you have any of these conditions before you start therapy.
Okay.
Julie, sometimes my patients ask, can they just have immunotherapy? Have we progressed to the point where we don't need to give chemo at all because you can so well characterize the individual tumor and just target it?
Yes, so sometimes we do use single agent monotherapy, immunotherapy. Other times we combine it with chemotherapy, but the goal is really to customize the treatment plan based on the patient's tumor biology. So select patients would be able to be treated with immunotherapy alone. Yeah. And
then another question that a lot of patients ask is, how do you monitor for recurrence, right? So let's say somebody had their primary treatment, is told that they're disease-free at this point. So then how do you monitor them?
Right. So a lot of patients understandably are concerned about disease recurrence. And we monitor in several ways. So the most important is history and physical. So you want to tell your doctor of any new symptoms that you've been having, any changes in your health. Second, we can use imaging studies. And usually this is done with CAT scan imaging every few months to monitor your response to treatment. We can also do this with blood tests. We have tumor markers that are available. We also have a new technology that's called liquid biopsy that we can use.
And can you just tell us a few more words about the liquid biopsy, what it is and what it shows us?
Yeah, so liquid biopsy is a relatively new technology, and it allows us to examine circulating tumor DNA, which means fragments of DNA from cancer cells that are circulating within the bloodstream. And we do this with a simple blood draw. So at the current time, liquid biopsies are being used mainly as a prognostic tool, meaning they can detect minimal residual disease, and they can also predict a patient's risk of cancer recurrence. And it's our hope that in the future, these biopsies will be able to identify patients who would benefit from adjuvant chemotherapy and ultimately monitor their response to treatment. And I will just add here that Stony Brook is participating in the first phase 3 clinical trial to answer that question, whether ctDNA can be used as a predictive biomarker, meaning identify patients who would benefit from chemotherapy after surgery. And a little plug for us, we were the #1 accruing site in the United States, so we're doing a good job.
That's great.
So Julie, one of the things that I think is so cool about liquid biopsy or ctDNA is that the test is built from the patient's own tumor. So once we take the tumor out or take a substantial biopsy, even from a scope, that tissue goes to a lab where they literally sequence it and then design a blood test specific for that patient. So I felt like, and a lot of patients tell me that they feel more confident because it gives an additional layer of personalization to the whole surveillance process.
Yeah. There's a question here from Jessica. How effective is CEA? She says that she had elevated levels, but nothing on imaging. And again, her disease was detected at a relatively young age. with no family history. So how reliable is CEA? We know that it can be variable in certain cases. It is elevated and it's useful to follow the disease, but then in some patients it's not.
Right.
Julie, you mentioned tumor markers. What would you say? How much
Right.
do you use it?
So serum tumor markers are useful in establishing a diagnosis of colorectal cancer. And we also use them throughout therapy as a measure of your disease burden. So if you're responding to treatment, usually we see decreases. If you've noticed an increase in your markers, sometimes this can precede cancer recurrence. Other times they just fluctuate in between cancer therapies. So it's, really looking at the whole person, not just a blood test, but, an array of things. But it's definitely useful.
Okay, very good. So, so we heard about surgery and chemotherapy. So I think it's my turn to tell you a little bit about radiation, which is the third treatment modality that we use for rectal cancer routinely. And radiation is, what I always tell my patients in this sort of consultation is basically radiation is high energy X-rays, right? So it feels like getting an X-ray, meaning it doesn't feel like anything. And unlike the diagnostic X-rays, which, scatter kind of all over the place, which is why you need thyroid shields and so forth when you get a diagnostic chest X-ray. Those are low energy X-rays, whereas the therapeutic high energy X-rays that we use for radiotherapy are forward directed and go where we want them to go, right? So where do we want them to go? The standard radiation treatment that comes before surgery in locally advanced rectal cancers, right? So this is based on some seminal studies where it was demonstrated that adding radiation, chemo together with radiation in most instances, to the surgical treatments reduces the chances of the cancer coming back. And it's best to do that upfront, meaning to do the radiation before surgery rather than after. Now, in some cases, we do end up doing a radiation after surgery because at surgery, it turned out that the disease was a little bit more far spread than we had initially thought that it was. But anybody for whom our imaging workup shows that it jumped to some lymph nodes or it had grown a little bit farther into the bowel wall, we think about radiation and chemo together. And the radiation is typically a 5.5-week course, 5 days a week. That comes together with one of the chemo agents that Dr. Gemmill has in her armamentarium. And it's, our one of our themes for today's talk is personalized care, right? Which we're moving more and more towards as we have more capabilities for delivering treatment and more treatment options. And one of my other favorite things to say is that radiation is by definition personalized care because it's anatomically based, just like surgery, and everybody's anatomy is different. And nowadays, with modern treatment planning and delivery techniques, we can conform our treatment much better to patient's anatomy and target specifically the areas that we want to target, sparing normal tissue toxicity. And the areas that we want to capture are, of course, where the primary tumor is, and also all the lymph node areas that it may have spread to. So this requires knowing the way that this cancer likes to grow, the patterns of spread, and trying to stay one step ahead of it. And of course, we also want to deliver it in such a way that minimizes the side effects, which are entirely based on where it is that we aim the radiation beams. So if we're treating rectal cancer, it's the side effects in the urinary bladder, so urination, and the bowel, right? So diarrhea and things like that. And of course, the whole process of treatment planning is trying to minimize the radiation that we give to each of those normal organs, and we know how much they can handle. And so what we try to do is give a dose that's below what they can safely tolerate, while at the same time giving a dose that we know to be effective for cancer control. So that's
Alex?
the, yeah.
So Wait, are there any areas of the body that you would use radiation for colorectal cancer treatment besides the pelvis? Because I heard you with rectal cancer, and that's in the pelvis.
Yeah.
So any other applications?
Absolutely, absolutely, yeah. So first of all, radiation is obviously used in most solid tumors, right? So over 50% of cancers that we treat require radiation at some point in their management. But specifically for colorectal cancers, both rectal and colon, we sometimes use them to treat metastases. So even when the patient's cancer has jumped to the liver, for example, right, which is a place that these cancers like to go to, this can be treated now with a modern radiation technique called stereotactic body radiation therapy, which uses very focused, high energy radiation in anywhere between 1 and 5 treatments. So this is very different from the 5.5 week course of radiation Monday through Friday that I just described for the primary rectal cancer. This is something for a metastatic site that targets specifically a lesion in a very focused, high energy, precise manner. And this is something that we use more and more for liver metastases and other parts of the body, for lung, particularly in patients who have a limited number of these metastases, right? So our notion of what constitutes stage 4 disease has been changing over time, right? A couple of decades ago, it was thought, well, once it's jumped to other parts of the body, it's stage 4, and stage 4 is stage 4. But now we know that that's not the case, and there is something called oligometastatic disease, where we know that there may be a benefit to going after each of these spots and trying to eradicate them. And this high dose stereotactic radiation is a good way to do that.
And also, I think people sometimes ask, or patients definitely ask, if they've had radiation once and the cancer comes back in that same spot, could they have radiation again?
Right. So this is a very important question to which the answer has changed dramatically, because again, 15, 20 years ago, the answer was short and simple, no. The reason for that was that if you give more, if you exceed the limit of radiation that you give to a certain spot, you can have really devastating normal tissue toxicity. And there was really no way to overcome that. But now, again, with this stereotactic radiation, that's where it comes useful, right? Because it has such sharp, what we call dose fall off, right? Which means that if you're giving this very high dose to the area that you're targeting, that you can identify very precisely with our modern imaging techniques, the dose of radiation within a few millimeters of what you're targeting could be, half or less than half of the dose that you're giving to your target. And so that's a major technological development that now allows us to retreat. So yes, now, it has to be done carefully. It requires special treatment planning, cutting edge technology, experience doing it, and image guidance during radiation treatment delivery. But it is something that can be done and that we are now doing more and more. So we have some questions. So I will.
ctDNA.
Yeah. So let's start with a question from Dawn. The question is, would ctDNA be helpful in monitoring for recurrence if CEA marker was within normal range at diagnosis in a stage 3 colon cancer? Let's direct it to Julie.
Yes, absolutely. That's a great question. ctDNA would be a useful indicator that your disease, there's micrometastatic disease recurring.
And then a follow-up question from Joan.
Can I just add on that?
Yeah, sorry. Yeah, go ahead. Go ahead, Deb.
Sorry.
Yeah,
but the reason that it's helpful is because there are two different tests. So the CEA is a test for something that the tumor of a circulating substance that the tumor makes, and not all colorectal cancers make CEA. We check everybody for it, but not all of them make CEA. So that's a completely different from the blood test to look for the circulating tumor cells in the blood. So that's why it's also helpful. I just wanted to clarify that.
Right. And we have a somewhat related question from Joan. Are liquid biopsies only used for colorectal cancer or for all cancers? Which cancers do you use it for? Let's go to Julie.
Yes, so another great question. ctDNA is not only used in colorectal cancer, but now it's being studied in a number of other cancers, including breast cancer. There are trials ongoing that is looking at this technology and the ways in which we can use it. Now, I will just clarify, ctDNA is different from detecting cancer cells within the blood. In advanced metastatic disease, we often, we can send a liquid biopsy sample with a tissue sample to look for genetic mutations that we can target with therapy. So in one instance, we're looking at cancer cells. In another instance, we're looking at these fragments of DNA that have left the cancer cell and are circulating in the blood. I hope that's helpful.
Great. Thank you. So just to go back a little bit, a couple of minutes ago, I was describing the paradigm of chemoradiation, which takes several weeks. So overall, this does tend to be a multimodality treatment that's somewhat protracted, right? That either starts with or ends with several months of chemo, and also requires several weeks of chemo and radiation at some point if we're treating rectal cancer, 5.5 weeks of radiation. So, at Stony Brook University Hospital, we have a pretty large catchment area in Suffolk County, and sometimes it's, for patients who live out east, it may not be very convenient to travel for an hour each way for their radiation treatments Monday through Friday. So just something to mention for patients in Eastern Long Island is that we do have the Phillips Family Cancer Center in Southampton, which is also part of Stony Brook. It's the same radiation oncology team, and we have our medical oncology colleagues who work there, where we deliver these treatments. And this may help accommodate those patients who live out east and for whom it will be inconvenient to travel so far, particularly for their radiation treatments. So I'd like to switch gears a little bit and talk about some of the hot topics or latest trends and updates in the field, right? So this multimodality paradigm in treating colorectal cancers that we're describing has been around for decades, but obviously as our understanding of the biology of these diseases and also our capabilities to treat them with new drugs, new technologies evolve, there are some hot topics that are discussed in our communities and some new approaches on the horizon. So let's spend a few minutes talking about that. One of the recent trends has been total neoadjuvant therapy, which takes some of the chemotherapy that patients would get after surgery and brings up front. Julie, can you tell us a little bit about that and rationale?
Yeah, sure. So this is a really hot topic, and the reason for that is because we looked at the data, and the old ways weren't working. Okay, so TNT, or total neoadjuvant therapy, is a way of treating locally advanced rectal cancer. And standard of care for treating locally advanced rectal cancer includes a multimodal approach consisting of neoadjuvant chemoradiation, surgery, and adjuvant chemotherapy. And what we found was, despite the complexity of this treatment regimen, our response rates weren't that great, and only about half of patients actually completed the full course of their scheduled chemotherapy. And this was due to a number of factors, postoperative complications, toxicities, which caused delays. So now the total neoadjuvant therapy approach delivers chemotherapy and chemoradiation upfront prior to surgery. And what the clinical trials have shown is that we have improved outcomes, and it's better tolerated. with reduced toxicity. So this approach has now become standard of care at many institutions, including here at Stony Brook.
Great. Deb, next question is to you. A lot of patients ask, well, okay, so now I've gotten my chemotherapy followed by chemoradiation. Can't we just skip the surgery? And what would you tell them?
So the answer used to be no, we never skip surgery. But now, again, from research and clinical trials, we know that the answer is yes, sometimes we can skip surgery. And because these treatment regimens are for people who have pelvic tumors, not necessarily just colon tumors, but rectal cancer in the pelvis, which is a more complex operation with more significant potential side effects after the surgery, it is certainly advantageous to consider whether or not we can skip surgery. So what we've learned over time is that some patients, if they have a complete response based on several different methods of assessment, a physical exam, a scope exam, imaging, PET scan, if those things are all negative, there is an excellent chance that surgery does not need to be undertaken. That said, if any of those things are not 100% perfect, we absolutely go ahead and recommend surgery, because even as good as our personalized testing has become at this point in time, imaging still doesn't have 100% detection for microscopic or tiny remaining cells of cancer in the body. So if we don't get the absolute clear picture from the testing that we've done, then we do recommend surgery. But now I would say that with TNT, the total neoadjuvant, up to 5 to 10% of people can potentially not have to go forward with surgery. And so for many patients, that's a big advantage.
Yeah, yeah. And, one of the questions that I get, sometimes, for example, I get a patient referred, by Dr. Nagle saying, look, this is a patient that may ultimately, if we can get a complete response, not want to undergo surgery, right? They're patients with comorbidities and so forth, for whom surgery would be higher risk. So what is there any way to maximize the likelihood of getting this complete response that Dr. Nagle just talked about? Again, historically, the success rates with eradicating all of the cancer with just chemotherapy and radiation alone have not been very high. But there are some things that can be done nowadays that we didn't used to do. One is, of course, total neoadjuvant therapy, where you can maximize by starting out the response by starting out with chemo and then moving to chemoradiation. But you can also increase the dose of radiation, right? This is something called dose escalation, where there was kind of a standard dose of radiation that we would always give for rectal cancers before surgery, because we know that it's safe. We don't really have to worry much about long-term toxicities, and it works. It works if after the chemo and radiation, the patient goes to surgery. But if we're trying to maximize the chances of eradicating the cancer even before surgery, then it probably is not enough. And so now with our modern treatment planning and delivery techniques, we can go to higher doses, and we do sometimes for tumors that are more locally advanced, that are more resilient, even in those patients that we are hoping to bring to surgery afterwards. But this is a disease that previously would have been very hard to control, and now we can try to do that with TNT and with dose escalation with radiation. Conversely, the question is asked if there are some patients in whom we can skip the radiation, and that's another hot topic. And there's a recent trial looking at that called the Prospect trial. And the question that it's trying to ask is particularly for patients with tumors that are higher up in the rectum, so closer to the patient's sigmoid. Now, we know that for colon cancer, this is a way in which colon cancer and rectal cancer are very different. For colon cancers, radiation doesn't play much of a role in management. There's not much benefit to it, but it clearly does for rectal cancers. So what about for cancers that are high up in the rectum, close to the sigmoid? And the question is whether chemotherapy alone followed by surgery would be sufficient. So, this is again, um, trying to personalize care, not use a cookie cutter approach, but realize that all the cases are different, and now we have more capabilities to tailor the treatment to a particular scenario. And so these are some of the hot topics that we're discussing, and there are multiple clinical trials that are either in progress or recently finished, or are coming down the pipeline addressing some of these questions. And one of the advantages of being a large academic tertiary, we have the luxury of being able to participate in all the cooperative group trials, having the expertise and the collaboration between the clinical and the research faculty to do a lot of this translational research, both in institutional studies and as participating site and cooperative group studies. And so this is something that we're very excited about and very active in. And anytime there's a hot new trial coming down the pipeline, we love to jump on it and get our patients enrolled.
Alex, so I would just add that for our research here is not just clinical trials about drugs. We're collaborating with our PhDs and other basic science researchers to look at the tumor biology, determine if special models can be made to better understand it, and our patients could be even offered studies to look at their gut health, because that is a hot topic where people need to want to understand how they can modify their diet and what they can do to reduce their risk of cancer or reduce the risk of recurrence. So there's a whole array. And here at Stony Brook, we work together in a multidisciplinary fashion. So that means we have group meetings called Tumor Board. And when we get together and discuss different patients and different cases, we always say to ourselves, is this patient appropriate for any kind of trial? What else can we offer them besides the standard care? I'll bet Julie would have a comment on that too.
Yeah, so as a medical oncologist, we have a number of trials looking at all of those things, risk reduction, more effective treatments. And you have to remember that everything we do to treat cancer has been studied in one way or another in a clinical trial. So enrollment in clinical trials not only helps you, but it helps patients down the line who who develop cancer. So it's very important to think about, either in your own care or in others'
care. Absolutely, yeah. Another topic that I think we need to touch on is the psychosocial support and wellness for patients with cancer diagnosis and their loved ones. We know that this is something that can be extremely challenging, both for the patient and for the family. There's a lot of fear, there's a lot of anxiety, there are a lot of life changes that need to be made, and it's very hard to navigate through it all. And so I think that here at Stony Brook we recognize very much that you need a team of professionals that are there to be with you every step of the way, to guide you, help you navigate the system and all the challenges that come with being diagnosed with cancer. Some of the examples, so this is where, as I think I mentioned in the beginning, our multidisciplinary team goes beyond just the surgeon, the medical oncologist, and the radiation oncologist, but it also includes nurse navigators, our nutritional consultants, right? So a lot of patients ask the question of, are there dietary modifications that will help? What should I be eating, right? There's psychologists. There is, clinical psychologists that specialize in psycho-oncology and psychological support for cancer patients that work with our cancer center. And then there are social workers, right? They're extremely important members of our team, and they're financial assistants to help with insurance questions and concerns, and all of this. basically is brought together to make sure that we practice in what we like to call caring, cutting-edge cancer care, right? So it's both cutting-edge technology and research, and a caring, personalized approach to our patients. Deb and Julie, you guys want to comment on this topic?
Yeah, I can weigh in. You know, cancer diagnosis is very challenging, not only for the cancer patient, but to families. It can be very disruptive in a patient's life, and we understand that the stress associated with that. And I would say that we are here to guide you and navigate through this process, to help you understand your diagnosis and steps we're taking to fight it, and to give you any support that you need. So, you know, we have a great team here and a great staff.
Dr. Nagle?
Yeah, you know, one of the things that patients reflect to me all the time is how cared for they feel. And a lot of that comes from not just us as the physicians, but our nurses and our nurse navigators and our nurse practitioners. And the nurse navigator is really a special role where the nurse is working one-on-one with the cancer patients to make sure that the entire treatment plan is clear to them, that the appointments for needed testing are coordinated, that any additional supports are accessed. So if social work is needed or financial assistance is needed, that nurse navigator is making sure and connecting with the patient to get that done to ease the entire treatment path. So I personally, the reason I love working here and love working with the other doctors is because we are part of this big team that routinely makes patients feel exceptionally well cared for.
Yeah, I would wholly agree with that. And there's nothing more gratifying than getting some of the feedback from patients who are, you know, super appreciative of the support they get from our team at the Cancer Center, and all the players there. So I think this covers most of what we wanted to talk about, most of our topics. You know, I would direct you. You see the phone number for the Cancer Center at the bottom of the screen here. So please feel free to reach out to any of us or other team members with questions. I'd like to thank everybody for tuning in, and please take this opportunity to to reach out to us now or later, and we're here to be a resource.
Thanks for joining us.
Thank you.